Hello students. So today we will talk about the venous air embolism, the method of detection and the treatment part of the venous air embolism. So venous air embolism, maximum time the venous air embolism, there is a small air bubbles found in the pulmonary circulations, and the patient will be asymptomatic, or their subclinical findings of the venous air embolism will be detected. So maximum minute air bubble which is present in the pulmonary circulation easily filtered by the pulmonary capillaries. But if the air bubbles are large enough, or volume is large, or the rate of accumulation is large, then only it will produce the symptoms. Okay. So asymptomatic to cardiovascular collapse. The finding will be from the asymptomatic to the cardiovascular instability, right? So the pathophysiology of the venous air embolism will be dependent on the volume of air entering, the rate of accumulation, position of the patient, and the height of the vein in respect to the right atrium, right? So many times the question will be asked about the lethal dose of the air which is entering in the circulation and cause death, even dangerous to the patient, right? So lethal volume of the air is 3 to 5 ml per kg of body weight, or broadly it is 300 to 500 ml of air at the rate of 100 ml per second, and it is fatal to the human. Okay. So, talking about the diagnosis of venous air embolism, it is the clinician should assess the clinical finding. What are the clinical symptoms? If the patient is awake, then he will complain of chest pain, continuous coughing, dyspnea, tachypnea, air hunger, or hypoxia will be seen. Patient, if there is cerebral embolism, then there is confusion, altered mental status, focal deficit, focal motor deficit will be seen, seizures will be seen, or clinically monitor. If we palpate, then there is tachycardia and there is hypotension. Okay. And there may be direct visualization by the surgeon or the clinician that there is absence of oozing, or there is air suction through the surgical site, incision site. Okay. And if the person is under general anesthesia, or the monitors is attached to the patient, then there is rise in the ET nitrogen and tidal nitrogen. There is reduction in EtCO2, unexplained hypotension, tachycardia, arrhythmias, which shows SVTs or VT, and direct observation of the air suction within the surgical field. I already told you. There may be mill-wheel murmur, which is detected on the esophageal stetho, precordial Doppler also. And if there is mill-wheel murmur, that is the significant sign, or it signals about the cardiovascular decompensation, right? And there is, if we, in monitor, in anesthesia monitor, we have SpO2 monitoring also. So there is reduction in SpO2 rate. If we send the sample for the ABG, then there is hypoxia and hypercarbia will be seen. If the person is having pulmonary artery catheter, then it will show there is rise in pulmonary artery pressure, right? So talking about the method of detection of the venous air embolism. So it will be divided up to highly sensitive, which can detect a small amount of the air, then moderate sensitive, then the lower sensitive method of detection, right? So TEE, precordial Doppler, transcranial Doppler, and the PA catheter, they are highly sensitive monitoring tool. What is TEE? It is trans-esophageal echocardiography, and it can detect 0.02 ml per kg of body weight amount of air. And it is basically the advantage of using TEE is that it can detect paradoxical air embolism, it can detect patent foramen ovale also along with the venous air embolism, right? And the TEE is in, but the drawback is, or we can say limitations are, it is an invasive procedure, so the expertise is needed when we are using TEE, right? Then precordial Doppler, it is, and transcranial Doppler, both are non-invasive methods of detection of VEE, venous air embolism. And precordial Doppler can detect 0.05 ml per kg of air, and the transcranial Doppler USG 0.05 ml per kg of air can be detected. But in precordial Doppler, actually both can detect air embolism, but they can detect different circulations, right? Precordial Doppler can detect venous air embolism, while the transcranial Doppler is very sensitive to detect cerebral microemboli. That means paradoxical air embolism. Means if the air is in arterial circulation, we should use transcranial Doppler, or if the air is in venous circulation, we can use precordial Doppler, right? So this is the difference. And PA catheter, it can detect 0.05 ml per kg of air, and the PA catheter, the drawback is this, that it can only be inserted in the patient who have multiple or significant comorbidities and where cardiac output monitoring is also necessary. And PA catheter expertise is also needed to put a PA catheter. It is an invasive procedure, right? And also the PA catheter, there is a fixed length and the orifice is small. So we can, if we want to aspirate the venous air, then it can aspirate, yeah, we can withdraw very small amount of the air, right? Then talking about ET nitrogen and ET CO2, they are moderately sensitive method of detection. And end-tidal nitrogen, because in many anesthesia monitor we don't have end-tidal nitrogen monitoring system, but it is the gas sensing VAE. It can detect the air venous air embolism 30 to 90 seconds prior the change in end-tidal CO2, right? And what is end-tidal CO2? End-tidal CO2 both can detect 0.5 ml per kg of venous air embolism, right? And end-tidal CO2, when there is venous air embolism, it is 2 mm, there is change in end-tidal CO2 along with hypotension, then we can suspect there could be chances of venous air embolism. But in COPD patient, the EtCO2 monitoring is, confusing. And the end-tidal nitrogen, the use of ET nitrogen is limited when there is nitrous oxide is used and also when there is hypotension, right? Precordial stethoscope, it can detect 1.5 ml per kg of air, and esophageal stethoscope, the same amount of air can be detected. And in both the group, we can heard about the Mill-Weak murmur, right? Oxygen saturation, direct visualization, ECG along with precordial and esophageal stethoscope, they are least sensitive and they can detect late changes in the patient, right? And post-operatively, if surgeons suspect there may be post-operatively, there may be patient is showing sign and symptom of venous air embolism. So if they suspect venous air embolism, then post-operatively for diagnosing the venous air embolism, we can ask for CT scan. In CT scan, there we can found air in the dural venous sinuses, pterygoid plexus of vein, and the cortical vein. Okay, now what is what is the management of venous air embolism, right? So first of all, direct observation, because we see the air is sucked into the venous sinuses or there is no oozing of blood from the incision site, so we can suspect. So inform surgeon and ask them to apply the saline soaked dressing over the surgical site, or along the bone edges we can put the bone wax. Then 100% oxygen to be given. Stop nitrous oxide air whatever we are using along with, and if hemodynamic instability, then inhalational agent should be also stopped. Transient bilateral jugular venous compression, if the cranial surgery is going on, so we can do transient bilateral jugular compression. The advantage of doing transcranial both jugular venous compression is there is rise in CVP and it will cause retrograde flow of blood, so there is no air entrainment, right? But the disadvantage of doing this jugular compression is there is rise in the ICP and the cerebral perfusion will be reduced, because there is carotid and carotid also to be compressed, so there is reduction in the cerebral perfusion, right? And along with there is carotid sinus, so unintentionally we can we can stimulate carotid sinus also, and there is severe bradycardia and cardiac arrest may be seen. So durant maneuver, what is durant position? Durant position is left lateral position and the trundle inward position, so that the air which is transported through the right right heart, it will not going to the pulmonary circulation, right? And along with during maneuver, we can aspirate. If the central line is there, then immediately we can aspirate the air through the central venous catheter. Adequate hydration always to be done in a cranial surgery or sitting position or in any case, because if we are giving adequate hydration or fluid to the patient, it will raise the CVP also, right? So there is less chances of the air entrainment. And also hemodynamic support. If the patient is hemodynamically unstable, we have to use vasopressor and inotropes also along with the fluid. And we can use norepinephrine, isoproterenol and dobutamine, right, if needed. And then ABG to be sent and managed according to the finding. If there is cardiac arrest, then we should go for CPCR chest, starting with the high quality chest compression and defibrillation immediately. Then if your institution has availability of hyperbaric oxygen, it should be given as soon as possible, as soon as venous air embolism is detected. And some article says it should be given within 6 hours of the detection of venous air embolism. Some says after 6 hours of VAE detected. So it is actually depend on the institutional protocol of using hyperbaric oxygen, right? Then perfluorocarbon, these are recently added in the management of venous air embolism, and the most common is FP43. They basically enhance the reabsorption of the air bubble because they are more soluble in the blood, right? So we will talk about the fluorocarbons in the next lecture and hyperbaric oxygen in the next lecture soon, right? So this is all about the venous air embolism, right? One important thing, that the use of positive end expiratory pressure or PEEP is controversial. Why it is controversial? Some article says we can use PEEP, some says we cannot use PEEP. It is actually depend on your personal experience, right? But it is controversial, so I suggest should not use PEEP, because if we use PEEP, that will improve your oxygenation, right? But if there is PFO, patent foramen ovale, then it will increase your chances of paradoxical air embolism. So should be avoided, because patent foramen ovale is may be seen in 35% of population. So it should be avoided, better to be avoided, right? And also if we are using PEEP, there is rise in the central venous pressure, right? And there is more hemodynamic instability. So its use is controversial. So this is all about the venous air embolism method of detection and the management part of the venous air embolism. Hope you like it. Thank you.